This is, of course, the NHS, and I know that Wendy Thompson is with us here today, and she has provided the Norfolk and Waveney STP submission in 2016 for home care, our vision to support more people to live independently at home, especially the frail elderly and those with long-term care conditions. And there were two things that struck me as I read this document. One was in their executive guiding principles of the National Health Service in the United Kingdom, they say, we will be system players and will work to a wider agenda beyond our organizational self-interest. And this is a significant and important change that we are undergoing in the healthcare reform in Quebec. It is challenging us to raise our heads and look beyond our own organizations in very significant ways. And then the second guiding principle that struck me is that we will take charge of our destiny and not shy away from difficult decisions. And I believe that there were some very difficult decisions that needed to be made in the year 2014 and 15 for Quebec. And I believe that there were some very courageous, albeit controversial, leaders who took on those difficult decisions, and we are living with them today. And so I'm inspired by these two guiding principles. And of course, the overarching priority, keeping me at home, which is going to be a big part of the examples that I'm going to share with you. With great admiration, shout out to Martine Alfonso, the interim CEO of the McGill University Health Center, for the difficult and courageous decision she took on to decide to be the interim CEO of the MUHC. And with all my admiration, I salute you here today. I will be speaking about four very specific examples, but I would like to provide a little bit of context, perhaps by way of inviting us to think about the healthcare system in Quebec and our healthcare systems internationally in the context of the state of our planet. And so there is a new book that has recently been published by Ken Gronbach. It's called Upside, Profiting from the Profound Demographic Shifts Ahead. So currently, the planet has 7.6 billion people. In 30 years, the planet will have 10.6 billion people. We will be adding 3 billion people, 1 billion per year, in the next 30 years. Could I ask for a show of hands of those people in this room who are under the age of 40? Fabulous. Welcome. Thank you. We know that innovation emerges from youth and young leadership. And we are very, very encouraged that you're here with us today. And we hope that you Google topics and see whether the speakers are actually saying things that resonate with what's online, and to give us your feedback as a result, because that's going to help us to think more creatively. The second data piece is one that I learned from the Wharton Business School and in 2010, and that is that there are more honors students in India than there are actual students in the United States of America. And in 2010, there were grave concerns about the level of education system in the United States and the level of graduation and what the citizens of the country were learning. And in 2010 at the Wharton Business School, they predicted that there would be an unexpected election result as a result of this constat in the education system. And so this is significantly important, I believe, as we are not very far from the United States, and we have our own issues to look at in this regard. And the third very important wave that I'm personally very concerned about, that I think we need to innovate and have a lot of dialogue on, is that yesterday the President of the United States declared a nationwide public health emergency around the opioid addiction crisis. And I believe that this is something that is going to significantly influence our need to be innovative and to provide quality of care to this population in the months and years ahead. Prior to the healthcare reform, financial sustainability of the publicly funded healthcare system was top of mind. The province of Quebec was worried about its financial quota with its lenders, and we have actually been successful in preventing that from happening, and there have been some significant financial gains in terms of doing more with less in Quebec since April 1st, 2015. We heard last evening from Jean-Louis Denis some of the consequences of that, and of course sick leave rates are up. They're up in our organization as well. However, a publicly funded healthcare system is something to be cherished and preserved, and it takes courageous leadership to be able to make that happen. I'm very fortunate to be able to work with the CEO, Benoit Morin, of our organization, and an Associate Executive Director, Marie-Claire Richer. The three of us make up what we call the haute direction of our organization. And a few numbers, 52, 1, and 5. 52% of the budget in April 2015 of Quebec was being spent on health care. We've managed to stabilize that and stop the growth of spending in healthcare that we, on the growth curve we were on. Number one, we are very proud at the CIUS Ouest de l'Île de Montréal that on the island of Montreal, in the last 3 years, in terms of financial performance, we are now rating first out of our organizations on the island of Montreal, so cost per capita, and we're fifth in the province. Now, that's a controversial statement to make because the questions may be asked, well, what have you given up as a result? And I believe that that's essentially some of what we're going to be talking about today. But we've also made some gains, and my focus as a pragmatist and an optimist is to talk to you today about some of those gains. So very briefly, this is who we are. We were created on April 1st, 2015, as I mentioned. This is the island of Montreal. The gray zone is the geographic area that our West Montreal Integrated University Health and Social Services System has population health responsibility for, approximately 375,000 citizens. And the dots represent the facilities that merged into our organization both in 2015 and 2016. We happen to be the organization uniquely in this way, where more of our facilities are actually off of our geographic territory than on our geographic territory. And this provides partnership challenges for us in very significant ways. So the 8 organizations that make up our what we call CIUS, West Montreal University Integrated Health and Social Services System, is St. Anne's Veterans Hospital, which came from the federal government to the provincial government in 2016. The Lakeshore General Hospital in Pointe Claire, it's 2 CLSCs and a long-term care facility. And written into Law 10 is that the head office of our organization will be in the city of Pointe Claire. And I mention that because I believe it's also significant to point out, with respect to population growth, the geographic area that has the highest population growth in the province of Quebec happens to be right here in Vaudreuil-Dorion, Notre-Dame-de-l'Île-Perrot, just to the west of our territory. And so for us, population growth, 10,000 births a year in our organization is a significant issue that we talk about daily. We also have the LaSalle Hospital, which has a very, very important volume of those 10,000 births happen at the LaSalle Hospital, and 2 CLSCs, as well as 4 long-term care facilities in LaSalle. We have 1,540 long-term care beds in our organization. We have the West Montreal Rehabilitation Centre. So we know that of those 10,000 births a year, 1 out of every 68 is going to be born with autism spectrum disorder. And the West Montreal Rehabilitation Centre dedicates itself to caring for children, families, and adults affected by a family member with autism spectrum disorder. Of course, the Douglas Mental Health University Institute, which is located in Verdun, and the Badshaw Youth and Family Centers, where we have our Youth Protection Center, as well as our youth group homes in that organization. And last evening I had a chance to speak about this with Wendy Thompson, and she was asking me, how has it been for Badshaw Youth and Family Services to be integrated into your health network? How has it been for them? And it's challenging because we're all on a steep learning curve together, and the people who are running it are teaching us. But certainly there have been gains, and I will speak a little bit about that as well. St. Mary's Hospital Centre, our flagship university teaching hospital, the second biggest in Canada in terms of family medicine training, and a very big jewel in with respect to all of the organizations that have come together. And Grace Dart in the east end of Montreal, a long-term care facility that offers long-term care to Anglophone patients in the east end of Montreal. So let me tell you a story. Please don't try to read the writing. I'm going to focus on the colored boxes. So in our organization on April 1st, 2015, the first person to be hired by the Minister of Health was the President and CEO, Benoit Morin. He reports directly in to the Minister of Health, Gaétan Barrette, and he was the first person. I was fortunate enough to be the second person to be hired as the Vice President Chief Operating Officer, is what I like to say. It rolls off the tongue a little bit more easily, Patricia, than the other title. 5 minutes. Okay, c'est bon. And so in this context, there were 2 tools that were given to us. This organogram, which is a standard one that they asked us to put into place across the whole province of Quebec, and what we call a cahier de charge, so 10 commands from the ministry that we had to put into place. The challenge here, clinical integration. The blues are the clinical divisions, the oranges and the greens are the administrative ones. I was invited in May. We were all invited. It was mandatory. Our CEO, our Associate Executive Director, and our home care and geriatric care teams to a forum on home care. And I'm delighted to say that our Directrice Adjointe, our Associate Director for Home Care for the Elderly and Long-Term Care for the Elderly is here with us today, Lydiane Janito. And they spoke a lot about the International Journal of Integrated Care. I'd invite the young people in the room to Google this journal because it was created in 2002 and will be growing into the future. And in this journal, there's a model that's provided for us to look at. And I would invite you to think about this model as examples are being discussed today. There are different definitions and contexts that the International Journal of Care invites us to think about. Jean-Louis Denis talks about this as well. The physician may have one definition in their head of what integration means. Les meilleurs soins au bon moment, best care at the right moment. The manager may see integration meaning communication between managers and sometimes with medical chiefs, whereas the patient will see integration as don't make me wait in several lines to get the services that I need. These are the definitions that are provided. I'm not going to go through them, but suffice it to say that there are at least 8 in the International Journal of Integrated Care that are put forward. And I think it's important for us to know where we're situated when we're talking about those definitions. If you think about the red dot right here in the middle as the patient, then we see clinical integration is what happens around the patient to improve patient care. Professional integration, how different disciplines work with each other in order to organize care around trajectories. We have had the experience of seeing alternate to a level of care patients who have been given discharge recommendations by the physician, and we're waiting for the physiotherapist for sometimes up to 5, 7, or 8 days in order to do their evaluation. And we've been drilling down on making those improvements. Organizational integration is obviously at the management committee, and we're focusing a lot on that in our center with a fundamental belief that teamwork at the Hospital Management Committee is going to lead to better outcomes for patients. And of course, system integration is at the level of the ministry, and I'm not going to spend too much time saying that we need to help different ministries to talk to each other to help us to get better funding, but that is certainly an issue for us. I'm going to skip ahead here and say that we have created a clinical integration committee on the 1st of April 2015, and we have generated 108 new initiatives of collaboration. That means that facilities that used to have to refer patients from one to the other, and the patient used to have to take their referral and go find services somewhere else, are now within the same organization, and we're encouraging them to build initiatives of collaboration together. The message of this slide is, over the last 3 years, in the first year, we had 1 per month that were being generated. In the second year, 3 per month. And now we're at a rate of 5 per month. These are small PDSA cycles that we're putting into place on integration. And Jean-Louis Denis invited us to look at indicators to measure the outcomes. And we're building those indicators into our system as we speak. 4 examples. Example number 1, the Code of Professions changed, and those group home members group home employees were no longer allowed to give medications to patients through gavage, and this was a big change. And we have 6 vulnerable clients who get their medications and food through gavage. We had a rapid rallying of our Director of Nursing, our Director of Elder Person Care, our Autism Spectrum Disorder services, our mental health services, all came together, and we brought in CLSC rapidly into the home, and in this way we prevented admissions to hospital. This may not seem significant, the numbers are small, but one admission for this type of a patient in a hospital can last months, if not years at times. The second example, and I will go to this slide, is that Mr. R is a person who suffers from severe mental illness. He has been living at one of our hospitals for 8 years. These are beds that could be used by many patients, as we know, especially from the MUHC in the last 24 hours, which is significantly shouting out to us, can you take more of our mental health long-term care patients into your organization? The reason why we can is because we have put into place collaboration and partnerships with the community, improved access to intensive rehabilitation for our severely ill mental health patients, and we have significantly reduced our length of stay of these patients in the emergency room, which is a big driver for emergency room overcrowding in Quebec. 2016, for these severely ill mental health patients, the wait time was 28 days before being able to get to the right service in order to focus on rehabilitation. In 2017, it's 8 days. We're not proud that it's 8 days, but we're going in the right direction. Small PDA cycles working on integration together. Example number 3 and 4 are related to our home care services and our partnerships with private long-term care facilities in the community. We have our Associate Director, Delegated Director of Access and Partnerships here, Dalia Toledano, who helped in this example. A gentleman of 101 years old. He was living with his wife in a semi-autonomous apartment, and the plan was for them to move into a private residence with much more services. As they were going through their move, the gentleman started to suffer from weakness, loss of autonomy, falls, respiratory infection, and advanced age. And we can see the trajectory of being admitted to the emergency room, long stay, length of time in the hospital. Because we've brought our partnership building with our private private long-term care facilities to such a level of communication since we've been created, as well as our home care teams into our hospitals, we were able to give a discharge to this patient because a multidisciplinary team targeted for 75 and overs in the emergency room worked with our other teams in the community. Within 48 hours, the patient was back in their semi-autonomous home, and our services of support to help them transition to their new private residence with more services followed them. There was no referral and wait time. The actual services were being provided. And so it is possible to do. The red box at the top of my slides are really the divisions that collaborated together in order to get to the outcome that was desired. So I'm going to skip ahead to some statistics. This is a lovely patient care trajectory in obstetrics, and a shout out to Patricia Lefebvre and Marie-Claire Richer, who are co-chairing between the MUHC and our organization, trajectories of care that we think can benefit the population. The beauty of this trajectory is that we're bringing mental health services to pregnant women and looking at maternal mental health. And we know through research that takes 17 years to get to 45% of the population that's likely to benefit. Focusing on maternal mental health will reduce cancer rates, cardiac disease rates, and mental health into the future. I'm finishing. So I invite you to think about the model again and where we fit in terms of clinical integration and professional integration, as well as working between facilities in order to get better outcomes for patients in the context of this model with triple aim outcomes. And I finish with a good news story. This is Madame Micheline Bélan. She is the president of our Beneficiaries Committee. She has won 2 years in a row the Beneficiaries Committee of the Year in the province of Quebec. And one of these very important reasons is the partnership between our organization and the Beneficiaries Users Committee that was identified as a factor in her winning that prize. And we're very, very proud of her and proud of the initiatives of collaboration that we've developed on together for our patients. And so I will close there and invite questions.